and do semen.
Fertility Docs uncensored site on all things fertility doctors around America conceive or just planning. You're here to guide you every step.
Hello, and welcome to Fertility Docs Uncensored, Fertility Center of Las Vegas. Two beautiful speaks and friends, Dr. Susan Center.
Hey.
Eblen of Nashville Fertility Center.
Intro, Carrie. I love your intro about myself, even though I don't know. It's a Sunday and I haven't really makeup on and all the stuff. I myself look good, but
Abby,
thank you, Susan. I promise. But
if I didn't like you for it, just beautifully put together. Showed you guys my outfit. Sitting there, you've got a button-down shirt on, you've got a cute jacket, you've got earrings, your hair has got that cute little thing. I'm really impressed. Always look put together.
Because I'm really interested. Time do you guys spend doing specifically what I'm really thinking about? I really like wearing lipstick. I'm putting on lipstick before I go to work. Nobody's going to see my lips. My mouth's gone.
I want to add one. How does it compare to what you did?
Interesting. I'll take it first. I probably time doing my hair. Same, but I probably focus on my too.
Under my eyes, and they look so.
I have this great cap your eyes that kind of and I'm I have paid more last year, but I like the lipstick too. But half the day I'm doing video. People are still who see me in person don't see my lips. People who see me on my video consult.
Video consult though, you don't really notice if people. I mean, I'm up on or not, kind of almost.
I'm so pale.
Yeah, me too.
I want the contrast. I think that I have actually cool of my hair and they're looking at myself all you happen to go to the bathroom and I'm walking up and see myself in the mirror. I mean, I spend my day actually looking.
Yeah. What about,
did you know that plastic surgeons show procedures ever have in the past because phenomenon of people staring being super critical? My day exclusively scrubs, spend hair, and I don't do makeup. So the difference between COVID is maybe versus 5 minutes. You have to actually think about before, what am I going to wear and making sure it's clean and pants matched. And I know that this is setting really an abysmally low standard, but I really embarrass myself okay, we're out. My standard because I was the primary doc in my practice. And the garage strip show where you walk into your door of the garage. I am proudly giving the neighbors a strip show.
It's Vegas.
It is Vegas stuff. But lose all the clothes. It goes straight into the laundry sanitation setting. Because if I'm not going to work, 15 minutes at the store, but that's why we have switched because I was the main person in the office where habits have stuck here.
What about you, Susan? Are you scrubs, less scrubs?
In the middle of the summer time period, I would come home as the person in my family who was having to go to the grocery store and things like that. So I would come home and kind of strip down. I have to say, when the numbers kind of got out of that, I wear scrubs on days that I travel or embryo transfer days. And then surgeons, I stay, I didn't go back to stripping when I come home type. It honestly difference with my family, everyone's unique. And so it's depending on what I happen to be doing.
Things started with COVID or something. I felt like I was going into never wear scrubs. And I kind of like to dress up out and putting stuff together. I just like doing that. I think that's sort of kind of I was mixing and so into what I wear. And so I skirts much at all so much so that I would even, and if you go to a mall, right, hose, I felt like I talked about World War II, so anyway, I haven't worn as many hose and as many dresses and skirts as I used to, but for a while, scrubs going into work. And after it came out with COVID, that it wasn't things that you could get COVID, it was more air. And so kind of about back to my more normal. Yeah.
No, I'm pretty low maintenance. I'm terrible at knowing how to not look like a clown. That's not my fault, but okay. Day to day. So this patient says, I've been secondary infertility. 30 recommending moving forward with IVF still haunts me. I've had a saline sonogram. Another test I should consider before staying.
So saline
has had 5 prior C-section with, and she's only 33. Seems like this is kind of a 2-part question. Other tests should she consider? I would assume for ovarian reserve testing, all of that's already been done.
Well, I don't know. I think sometimes patients that have come from other practices, sometimes if they're fairly young, or people don't routine, but if it hadn't been done, I'd definitely done. And same thing with sperm. I have several people right now, sperm counts are lower. So basic things do too. do ovarian testing, because you don't want to find out at the end of that arm or the tubes are blocked. I mean, so I would definitely do those things that you would add in, Susan.
But also, if I see a lot of people who come in fertility and they're screening, she's not like a fragile egg, because people, even though they may have testing, there's actually, they too also getting pregnant, and things like that. So an additional thing, kind of looking that could add in, but of unexplained infertility. When I talk to my patients, number one, unexplained infertility is a diagnosis, and I completely understand. However, in perspective, in that, do you find a reason? Fertility problems, it's a lot harder than infertility. So thing that was and all the intricacies, all the thing in early pregnancy, a book about everything we can actually a quarter is and so there's that happened that we technology actively test and obvious helping make babies, and the likely disturb something that, and so still lots of things field in how we, it's just there's so many, so reason doesn't mean that there is not something going on.
Well, and even if we don't find a reason, we still want to improve the chances. So we want to, if we don't know exactly what the problem is. And, I always tell patients, if you know the reason why, but I started out and I had a surgery on and Emily, just because that, I remember her saying, well, and then we'll know the reason why. It's horrible endometrial. We found the reason why. You're happy that you have. I think the opposite is, if you have unexplained infertility, you have a pretty good chance of being too far distant in the future. Where a difficult problem to do. It might involve doing something a lot more like IVF. So that, I guess, is a way to say it. If you had,
I mean, I agree with everything. Unexplained is not the ways that we can approach it. The things that we can find are often bad and ugly, and it haunt you. And the other way to look at it is that everything was equally as bad before. I just got really lucky because I had a child spontaneously without having to go through treatment. And so there's a decent chance that whatever was going on before, whatever's going on now, and you just got really lucky. Nearly as hard for, and so those crazy stories that go around the office of, hey, on her own, where everybody, and the reason they're studying, they shouldn't have gotten pregnant, and they did anyway. And I don't give this maybe as much brain as you're giving it, and just say, routine things. We're doing preparatory step. It worked the first time. Naturally, we don't know why, and let's make this a distance. I know that I would dedicate the haunting brain space, as the listener has given. All right. So our top, Abby, can you reverse my tube? What that is likely to, why are they asking that?
Comes in to discuss a tubal reverse child before. And a lot of times we'll see that, maybe the partner has not had a child, maybe, and so therefore they want to have a baby together. And so, a lot of times people are really intimidated that we can potentially do. And they think, well, if we just put my tube, get pregnant. And so it is a surgery, that if it works sometimes, but there's a lot of know exactly where your doctor, meaning we don't know where the uterus is or close to the tube, and that can make a difference if tissue was removed. And that, a lot of those things, even if we read and I learned the hard way, see what they did, a lot are in what they say. And so it's a good sense of how much tube was removed. I guess what I'm alluding to, just you never really know as a surgeon, and you never really know as a patient, that down the road can maybe not be successful access.
So just to back up, so when people hide, there's a couple that can happen. Things called fallopian, little ring that's placed on the fallopian tube that essentially kind of squeezes it shut. And that damage can cause scarring that helps kind of ensure that meet up together. It has the highest chance amongst the different types. Permanent sterilism. Those are sometimes placed. Sometimes the fallopian tube is, so that's most awful. Tubal ligation, laparoscopy, and between a 1 to 3 fallopian tube is create the tissue that worm to meet up. And of tubal ligation is where of the fallopian tube really cut out and some ends are cauterized.
There's also a clip. And Susan, does it really matter?
Well, if you have theoretically probably going to have a tube that put back together, having a segment burned or actually.
But it also depends on how much to put on the tube. 3 or 4 clips, and then you think it's going to be damaged.
Absolutely.
There's also the issue. People are not receiving so much, but there was a time when a popular way of blocking off the issue was, and is the other one, these tiny were put inside deliberately issue, so it will be blocked, is that creates a barrier for.
Mm-hmm. That's true. I have never, have you?
I don't really know that that's right where the tube damaged. And that's really a tough, the tube. And in fact, one of the tubal reversal is, so the two things, remaining segment of the tube and so whether you put a clip or no matter what you do, there dies. And Susan mentioned for cautery, you damaged a bigger segment just because it causes the tube, not only where the areas kind of on as well. So you never was going to be left. And also where the clip or where the, ideally we'd like to, because that piece of that dead piece in the middle, that whatever, and you sew those, they're about equal in size, those together, even though they're microscopic, to kind of oppose those to cause, it's just a big piece of tube back together for the size segments together. It's tricky and you never know.
So Abby, how ideally want left on the best outcomes?
I'm tried at centimeters, but I could be off on that though. But typically, if I've done tubal ligation, meaning your baby, and then a lot of times if there's a path measurement, and usually most of the time it's probably going to be one that, well, if a much bigger segment, in some cases, if the whole, that's a problem.
Which we're saying,
and that's why it's always important. If you're reversal done, you need to record a note. That's a note that a doctor dictates at the time that they do your tubal ligation. And a lot of times, just reading between the lines, you can think that will work for you. For example, scar tissue in your pelvis to the tube can be damaged. If far into the tube is damaged, ligation, that's not going to be a tumor. So it's good to get a copy, see what the doctor did, because same type of procedure. And when they're dilation, you're telling them, and they don't want to be the doctor after their sterilization. So I don't blame doctors for burning a lot of the tube because you don't want to have more children. And so figure out what they've done before we try.
So how is a tube different for someone, their tubes blocked and we're done having kids throughout the course of their infertility?
Tube that is damaged. Somebody who has blockage that has naturally a collection or endometriosis to, whatever may have caused scarring, because it's essentially some form of scarring, that entire tube has been exposed. And both of them have been exposed. And again, I talked about kind of a tube, it's a dynamic organ. It has these little projections from an embryo get where they need to, if we don't do just open, is actually more harm than good, because of ectopic pregnancy, wrong place, that can be a life-threatening condition. In 2021, we like to avoid those things.
Important thing too, when you're talking about make us want to age. So fallopian tubes, and you may 4, but if you're now over 40, your chances are reversal. And so think about something that's a lot more successful was to doing a tubal reversal.
When you're thinking about have a male partner, is have him get a semen analysis, because the last thing we want you to do is go through an invasive surgery and then come to find out we don't pregnant with something short IVF anyway. That I see a case go and get there in Texas, get there across the border, and things expensive, but really been that male and then people come back and it's like HSG, the tubes are open. We end up having a male factor. So that I encourage patient their part is if it asks for a semen analysis before.
What are your thoughts, Carrie?
Move forward with the next. How do you make the determination of, and this is different?
I usually age, but usually in the front end way, I like patients before they try and get pregnant, or the swelling and the risk with tubal reversal is pregnancy. And so it's once you do get pregnant, all your doctor's office, we want to make sure that you have a pregnancy in your uterus. So your chances about, maybe 5 to 10% of having a tubal reversal. So you really very quickly, and then assess kind of, where the pregnancy is. You wait 2 or 3 months, depending on your age. If it's been more than general rule, and that can be, if you've not gotten pregnant at that time, a tubal patency test, or to look and make sure if your tubes are open, age and your ovarian reserve, just like human reproduction, just take tubes are open. But if over 35, I wouldn't give it a real long time. You're a lot more aggressive, you more quickly.
I agree with that. Sometimes most of the people who have had children previous, they can get lured into I've had babies before, I don't have any problems, and is not always the case. There was obviously one factor, but your best chances of getting pregnant. And so I would side of caution. I mean, this group of people obviously are very actively trying to seek pregnancy. They're very intentional about you haven't gotten pregnant. That it's very reasonable to kind of get potentially consider something to the regimen to prove egg and sperm interaction.
With all of that. I think that's, the other thing that people always do to make sure to
go to somebody who does reversals. I would say most reproductive do mini tubal. People who do them do quite a few military because have lots of experience. Just like everything else, you want to go to some of it.
That one is surgeon.
Yes.
Yeah, too is a lot of fertility coverage. Commercials are not covered because it's as opposed to for some other reason should be taken into consideration too. If you had fertility coverage and you had coverage for IVF, then hands down, I'd go the route of IVF as opposed to choosing tubal reversal.
Mm-hmm.
All right, excellent. Any other things you guys want to add to that? Do you think that we're Jen?
I think we got all
of the major points. Wonderful. Thank you, Carrie, working with you. It's such a nice welcome to our audience. And be sure to tune in next. Be sure to subscribe to iTunes. We would love to hear
us at Fertility Docs Uncensored appointment with any of us. Or a question that you have about be answered on the Podcast Anonymous. 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 Podcast Anonymous, 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 Podcast